Hey guys, welcome back to my channel, The ENT Resident. Today, I'll be starting a series of topics which is going to be about diseases in the nose. So, the first disease that I'll be picking up today and discussing is atrophic rhinitis. So, we'll be discussing this disease under these broad headings: the definition of it, age and sex, prevalence, history of it, types and etiology, pathology, clinical features, investigations, complications, treatment, prognosis, and differential diagnosis. So, the complete video will be kind of a full length, long answer to questions you get in theory, as well as this will also help you in your practical cases when you get short cases of atrophic rhinitis. So, this will also help in answering all the Viva questions you get from here. So, let's get started. First, what is atrophic rhinitis? Now, atrophic rhinitis, firstly, is a chronic inflammatory disease of the nose. This is primarily important. So, first of all, it is a chronic inflammatory disease of the nose, usually of unknown etiology. And it is characterized by a few important characteristics like atrophy of nasal mucosa, turbinates, and greenish crust formation, and very importantly, roomy nasal cavities. So, what is atrophic rhinitis? It is a chronic inflammatory disease of the nose, usually of unknown etiology, and which is characterized by atrophy of nasal mucosa and turbinates, greenish crust formation, and roomy nasal cavities. This is how you define atrophic rhinitis. Next, we move on to the age and sex prevalence in the disease. This disease is usually more commonly seen in females rather compared to males. This is something that can be probably explained as a theory, which is described in the etiology of the disease, which aims at because of hormonal disturbances, it is more prevalently seen in females compared to males. And if you come to age, this disease usually starts around puberty, and you throughout the young adult age you'll see the disease progressing, and somewhere around middle age you'll start to see the regression of symptoms, and especially in females after menopause the symptoms of the disease completely disappear. So that's the age and sex prevalence of the disease. Let's know a little bit about the history of the disease. This disease was first called as ozena. This is also a term that you need to remember. Sometimes you're asked what is the other name given to atrophic rhinitis. Dr. Spencer Watson called it ozena in 1875, and Dr. Bernhard Frankl in the next year, which is in 1876, described the triad of the atrophic rhinitis, which are the three important features that you see in the clinical features that you see in the patient. First is a fetor, which is basically the foul smell, which is a characteristic feature of this disease. Second, there is crusting, and thirdly, there is atrophy of the nasal structures. So these three form the triad of the atrophic rhinitis. Next, we move on to what are the types of atrophic rhinitis. Now, atrophic rhinitis, depending on its cause, is divided into two types: primary and secondary. So, primary is the type when the exact cause of the disease is actually not known. So, in this case, it is hypothesized into different theories. So, the theories, there are about 7 theories, 7 different possible causes that are attributed, 7 different possible reasons behind this unknown etiology of atrophic rhinitis. You can remember with this particular mnemonic: hernias. So, H is for hereditary, E is for endocrinal disturbances. R is for racial factors. N is for nutritional deficiencies. I is for infective causes. And A is for autoimmune cause. And lastly, S is for surfactant deficiency. So these are the possible theories that have been hypothesized that could be the reason of primary atrophic rhinitis, where we do not know what is the exact cause. Now I'll talk about each one of these first. So first, let's talk about hereditary causes. Usually, hereditary. It has been seen that these cases appear in more than one member of the same family, and this is usually seen in an autosomal dominant inheritance pattern. So that's the first theory. Second is endocrinal causes. So in endocrinal causes, what we see is the disease. Why we are thinking that there could be a endocrinal disturbance behind this disease is that the possible reasons are, first of all, we see that the disease starts around puberty. It is involving females more than males. And this disease, somehow, the crusting and the foul smelling odor that comes along with the disease tends to cease after menopause. So, all of these factors together kind of point towards an endocrinal disturbance in the patient that might be leading to the atrophic rhinitis development. Next, we move on to the third theory, which is racial factors. So, it has been seen that the incidence of this disease is more in white races compared to the natives of Africa. Next, we move on to nutritional deficiencies. So, atrophic rhinitis has been seen to be more in developing countries and in poor households. We have been seeing that the incidence of the disease is very, very low in developed countries and well to do families. So, from there, it has been hypothesized that maybe a part of the disease could be caused from some kind of nutritional deficiencies, like it could be vitamin A, vitamin D deficiency, or iron deficiency. It's not exactly known what exactly leads to it, but these are the possible deficiency in terms of nutrition that may lead to this disease. Next, we move on to the fifth one, which is infective causes. So, infective causes, various organisms have actually been isolated from cases of atrophic rhinitis. And these organisms include Klebsiella ozeni, Perez bacillus, diphtheroids, Escherichia coli, Streptococci, Staphylococci, and Proteus vulgaris. And all of these organisms, however, these are not considered to be the primary cause or the primary causative organism which is leading to this disease. Rather, these are responsible for secondary invasion after the disease has already developed, and after the secondary infection with these bacteria, that it leads to foul smelling odor coming from the nose. So, these are all the infective reasons that are there. Next is autoimmune. So, the autoimmune process that happens in the body here is that a viral infection or any other such unspecified agent sometimes triggers an antigenicity of the nasal mucosa. Now, when there is antigenicity of the nasal mucosa, the body treats it as a foreign agent. As a result of which the body reacts to it by a destructive process to these antigens which are getting released from the nasal mucosa. And as a result of this, there is atrophy of the nasal mucosa, the turbinate bones, and hence leading to roomy wide nasal cavities. That is the aspect of autoimmune process that could be leading to this disease. And lastly, the last one is the surfactant deficiency. So it has been seen that there is a significant change in phospholipid profile seen in the nasal aspirates taken from atrophic rhinitis patients. So it has been hypothesized that there could be a possible role for surfactant deficiencies. So these are the 7 theories that are used to explain primary atrophic rhinitis, where the exact cause of the disease is not known. And you remember all of these causes by this mnemonic called hernias. Next, the second type of atrophic rhinitis is secondary atrophic rhinitis. Secondary, as you can already guess, here atrophic rhinitis occurs secondary to another cause. And what are the possible causes that could lead to secondary atrophic rhinitis? These causes involve causes like, for example, extremely deviated nasal septum. So, in extremely deviated nasal septum, you see that on the side of the nose where it becomes very wide and roomy, on that side of the nose, it leads to an unilateral atrophic rhinitis. There could be other causes like chronic purulent sinusitis. Another very important cause of secondary atrophic rhinitis are the chronic granulomatous diseases of the nose. These include TB, lupus, leprosy, syphilis, rhinoscleroma, vaginous granulomatosis, and many more. It can also be iatrogenic. Iatrogenic meaning caused due as a result of a side effect of a surgery. The most common cause in iatrogenic reasons is the excessive surgical removal of turbinates. The other causes include rhinosporidiosis, myiasis, and radiation to the nose. So, these are all the causes of atrophic rhinitis, which leads to secondary atrophic rhinitis. When atrophic rhinitis like condition develops secondary to another condition of the body. So, these are the two different types of atrophic rhinitis. Another thing that I missed about is in primary atrophic rhinitis, you can further classify it into two types. There is something called a type 1 and a type 2. And these two types can actually differ based on what you see pathologically or histologically. So, in type 1, histologically, you see end arteritis and periarteritis. And these patients are actually benefiting from vasodilatory effect of estrogen therapy. Whereas in type 2, histologically, you will see vasodilatation of capillaries. Here, if you give estrogen therapy, it will actually worsen the condition. The treatment aspect is something we'll discuss about in the later part of the video. So this is all about the different types of atrophic rhinitis. There is primary and secondary atrophic rhinitis. Primary is when you do not have an exact cause. The cause is unknown, and this primary atrophic rhinitis can be further discussed in two different types, which is type 1 and type 2. And these two have different histological appearance. And secondary atrophic rhinitis is when the disease develops secondary to another condition of the body. So, this is about the different types. Now, we'll move on to the pathology of atrophic rhinitis. What do you see? So, can you tell me what is a normal epithelium of the nasal mucosa? So, the normal epithelium of the nasal mucosa is a ciliated columnar type of epithelium. So, you can see this, the first image over here. This is a normal epithelium of the nasal mucosa. These are the cilia that you can see. These are goblet cells. This is a ciliated columnar type of epithelium. What happens in pathology of this disease is this ciliated columnar epithelium gets lost. You can see in this image, the second image over here, the cilia are getting destroyed. They do not look normal like this first image over here. So first of all, the ciliated columnar epithelium is lost, and this gets replaced by stratified squamous type of epithelium. Other than this, you see atrophy of certain structures like atrophy of nerve elements, atrophy of seromucinous glands. In the third picture over here, you see right over here, these are the vessels. These are the arterial vessels in the nasal mucosa, and these arterial vessels also undergo changes. Here you are seeing obliterative end arteritis of all the arteries, and as a result of which the blood flow to the nasal mucosa is getting destroyed. So if we have to discuss about the pathology, you can actually divide the pathological changes that you see in atrophic rhinitis into two. One are the epithelial changes, and second are the vascular changes. So amongst epithelial changes, the first thing you see that ciliated columnar epithelium is getting lost and it gets replaced by stratified squamous epithelium. So there is a loss of cilia. Then there is atrophy of nerve elements and atrophy of seromucinous glands. So all the goblet cells that you're seeing over here, these are the normal goblet cells. These start disappearing. So these lead to the atrophy of nerve elements and seromucinous glands. And the second aspect are the vascular changes. So amongst vascular changes, you see that the arteries in the mucosa, the periosteum, and the bone, it starts showing obliterative end arteritis and periarteritis in type 1. And in type 2, which I've already discussed, the type 1 and type 2 parts of primary atrophic rhinitis, type 2 shows dilated capillaries and also the venous blood sinusoids start atrophy. So these are the vascular changes that you see in the pathology aspect. And also, grossly, you will see that the bones that form the turbinates, these also undergo resorption, and that leads to the wide, roomy nasal cavities, which is a very characteristic feature of this disease. Other than this, there are some other tiny developments, like you can see an increase in alkaline phosphatase activity in this disease, and also paranasal sinuses are very small in this disease because there is arrested development. It does not develop to its complete potential. So these are all the pathological changes that you see in atrophic rhinitis. Next, we are going to discuss about the clinical features that we see in the disease. So whenever we talk about clinical features, we divide it into two parts: symptoms and signs. Symptoms are things that patient complains about, and signs are the features that a clinician notices in a patient. So first, let's talk about the symptoms of the disease. The first very important symptom is foul smell coming from the nose of the patient. Now, this foul smell that comes from the nose of the patient kind of makes the patient a social outcast in the society. However, the patient himself will be unaware of the smell that is coming from his nose. This condition is known as merciful anosmia. This is a very, very important feature that we see that the patient complains about, that his family members or people around him will be complaining of a foul smelling odor coming from the nose of the patient. However, the patient himself or herself will not be aware of the foul smell. That happens because of the anosmia, which brings us to the next clinical feature or the symptom, which is anosmia. Now, why does this anosmia happen? There are a few reasons behind it. First of all, what happens is the olfactory elements, neural elements that are there, they kind of get lost and destroyed in the process of the disease. Next, second, what happens is this disease is actually characterized by a lot of thick secretions and crust formation in the nose. Now, these secretions and crust, they kind of end up covering the whole of the nasal cavity, which also includes the olfactory area. And once the olfactory area gets blocked, you cannot perceive smell anymore. So that's the second reason. And the third reason is there is degeneration of seromucinous glands, which I have already discussed in the pathology section of it. As a result of this seromucinous gland getting degenerative condition, it leads to something known as xerostomia, which is basically drying up of all mucus in the nose. And when there is insufficient mucus available in the nose to dissolve the odoriferous material, it leads to anosmia. So anosmia in the patient occurs because of these three reasons. First is the olfactory neural elements are destroyed. Second, secretions and a lot of crust covers the olfactory area, which prevents the air current to come in contact with the olfactory mucosa. And third of all, the destruction of the seromucinous glands leads to xerostomia, hence, as a result of which there is insufficient mucus to dissolve the odoriferous materials. Next, we move on to the third symptom, which is nasal discharge and crusts. Now, what happened here is this disease is characteristically defined by the greenish black discharge and crusts that fill up the nasal cavity. And these, when you try to remove these discharge and crust, sometimes it leads to epistaxis. So the patient will complain about bleeding from the nose when they try to remove the crusts. And as a result of this greenish blackish discharge and crusts, it fills up the nasal chambers, and as a result of which you find that the patient complains of nasal obstruction. Although when you clinically see the patient, you'll see that they have very wide roomy nasal chambers, and despite having wide roomy nasal cavities, they are complaining of nasal obstruction. This is because it gets filled with all these thick discharge and crusts, hence which leads to nasal obstruction. Epistaxis happens when you try to remove the crusts. The patient may also complain about a foreign body sensation in the nose because of the presence of all these crusts. The patient also presents with a very Slavic facies, where the face is broad and the nose is small and wide. Very rarely we may see maggots, patient coming with maggots. This is only when the hygiene of the patient has not been maintained or he has not come for a diagnosis early in the disease. The diagnosis is made late, and because of the unhygienic conditions in the nose, it leads to maggot formation inside. And lastly, the patient may also come with hearing impairment. Now, why does hearing impairment happen in atrophic rhinitis? This can happen when all these crusts fill up the nasal cavity and go up to the nasopharynx and blocks the eustachian tube. When the eustachian tube gets blocked, it will lead to middle ear effusion, and hence that will lead to development of impairment of hearing. So these are all the symptoms that the patient will come to you with. Most important, the most characteristic one is merciful anosmia, nasal obstruction despite having wide nasal cavities, thick crust and discharge. The characteristic description of this is greenish or grayish black discharge and crusts. And when you try to remove these crusts, it can lead to epistaxis. Next, let's move on to the signs. What are we gonna when we examine the patient? What are the things that we are gonna see in this patient? Let's talk about general signs. General sign is that we will notice that there is a foul smell coming from the patient. Next, we come to anterior rhinoscopy. What are the things that we are going to notice over here? We'll see, as you see in the picture over here, we will see that the nasal cavity is full of greenish or grayish black dry crusts which cover the whole of the nasal cavities, over the turbinates, over the nasal septum, over the floor of the nose. And when you try to remove these crusts, it leads to a lot of bleeding. And after you have removed these crusts, you will see that the nasal cavities are very roomy. And in this roomy nasal cavity, you will see that the turbinates have undergone atrophy. That is a very, very important sign that will help you in diagnosing the condition as atrophic rhinitis, where you will see atrophy of nasal turbinates. As you see in this picture over here, this is a normal nasal turbinate. These are all the turbinates. You see in this second image over here that all the nasal turbinates have undergone, the bony nasal turbinates have undergone atrophy. This is a very important feature. Sometimes the bony turbinates will be reduced to just a ridge on the nose. Other than this, you will see that the nasal mucosa turns out to be very pale. And because of the very destructive process that happens in the nose, you may also see septal perforation and dermatitis of the nasal vestibule. And sometimes, because of extensive damage, there is one deformity that you will see over here, which is known as saddle nose deformity. When the skeletal structure of the nose is destroyed due to the extensive degeneration and atrophy that happens. So these are all the findings that you see in atrophic on anterior rhinoscopy of the patient. Next, coming to paranasal sinuses. As I already said, the paranasal sinuses are actually going to be very small and underdeveloped. This happens because of the arrest and development of the paranasal sinuses. Next is atrophic pharyngitis and laryngitis. So, what happens here when the disease is very extensive and it reaches and involves the pharynx as well as the larynx, you'll see similar changes that you've noticed in the nose. That the pharyngeal mucosa gets lined with very crusts like these greenish, blackish crusts all over it, and there's atrophic changes which starts happening in the pharyngeal mucosa. And in atrophic laryngitis, when the larynx gets involved with similar changes, the patient will actually come to you with cough and hoarseness of the voice. And lastly is hearing impairment, which I've already spoken about. So you can do an examination of the ear as well to see if you get any findings. So these are all about the signs of the nose. The anterior rhinoscopy findings are very, very important over here. This will help you in clinching a clinical diagnosis from the patient. The greenish or grayish black dry crusts, try to remove it, it causes bleeding. And once you have removed it, you see that the roomy nasal cavities and there's atrophy of the turbinates. Sometimes you may even see septal perforation or a saddle deformity of the nose, and the nasal mucosa appears pale. So these are very important signs that you see in a patient who comes to you with atrophic rhinitis. And these signs can actually help you in clinching a clinical diagnosis here. Next, we move on to investigations that you do for such a patient. The most important investigation here that you'll be doing is a CT scan of the nose and paranasal sinuses. And what are the features that you'll be noticing here? This image over here is a CT scan of the nose and paranasal sinus in a atrophic rhinitis patient. You'll see that there is mucoperiosteal thickening of the paranasal sinuses. These are the maxillary sinus on the CT. You can see this part that there is a mucoperiosteal thickening which forms inside the paranasal sinuses. You'll also see a loss of definition of the osteomeatal complex because of resorption of the bulla and the uncinate process. You see everything is kind of destroyed over here. And next is you'll also notice a hypoplasia of the maxillary sinuses. I've just discussed that paranasal sinuses are going to be very small and underdeveloped. You can see it over here. These are not the normal size of a maxillary sinus. There is hypoplasia of the maxillary sinus. You see an enlarged roomy nasal cavity on both sides. And you can see how all the structures, the bony structures, have been destroyed. You can't see any turbinate bones. There's barely any turbinate bones to be seen over here. So there is an enlargement of the nasal cavity with an erosion and bowing of the lateral nasal wall. So these are all the features that you end up in seeing in a CT scan of the nose and paranasal sinuses. Next, we come to a nasal swab. Why would we do a nasal swab? This nasal swab will actually help us in ruling out infective granulomatous conditions. I've already spoken about the secondary atrophic rhinitis, where one of the important causes over there are chronic granulomatous diseases of the nose, like TB, lupus, leprosy, syphilis, rhinoscleroma, etc. So, all these diseases can be diagnosed with a nasal swab. Next, chest x ray, Montauk's test, and a sputum for AFP. All these three can help you in ruling out TB. Next is a serological test. Serological test can help you in a diagnosis of syphilis and all these other granulomatous conditions. A very important test here is a nasal biopsy. Nasal biopsy can help you in confirming the diagnosis of the patient when you see the pathological and the histological features that I've already described previously. The nasal biopsy will help you in confirming the disease. And where do you usually take the nasal biopsy from? The site that you take it from is usually the inferior turbinates. And lastly, there's urine and serum protein, which can help you in diagnosing SLE. So, most of the other tests that you see over here are used to diagnose the chronic granulomatous diseases of the nose. And the two very important, other than that, is CT scan and a nasal biopsy, which will help you in clinching the radiological diagnosis of the disease. So, that's all about the investigations. I've already discussed all of this. Next, we move on to complications. What are the complications that you see in this disease? There can be a deformity of the external nose, I've already said it. When there is extensive damage of the nasal structure, it leads to saddle deformity of the nose. There can be a septal perforation when the nasal septum gets atrophied. It can lead to myiasis, or basically maggots entering the nose. This is only when the disease has progressed very far and the patient has not received treatment. There can be chronic sinusitis, anosmia, chronic pharyngitis, pharyngeal sicca, laryngeal sicca, CSOM, lung abscess, and obviously there are a lot of psychological problems associated with the disease because of its nature. So these are the complications of atrophic rhinitis. Next, we move on to treatment. So, treatment, we can divide it into two parts, medical and surgical. It has been seen there is actually no specific treatment which is there which can cure the disease in case of primary atrophic rhinitis, where there is no cause as such to be treated. So, in this case, the aim of medical treatment becomes, first of all, to maintain nasal hygiene and nasal hydration. And the second aim of medical treatment is to minimize crust formation and the associated foul smell that you get from the patient. So these two are the primary aims of the medical treatment here. For one is the most important one here is to maintain nasal hygiene and nasal hydration, and second is to minimize crust formation and the associated foul smell odor that comes from the patient. And let's discuss more about what are the different medical treatments that we can give. First of all is the nasal irrigation and removal of crusts. This is done to maintain the nasal hygiene of the patient. Here, what you should do is you should usually run the solution that is made through one nostril and the solution comes out from the other. What this helps to do is it helps to loosen the crust and removes the discharge from the nose. Initially, when the patient comes to you, you should prescribe it for 2 to 3 times a day. And once the initial period is over time later, it can become once in 2 to 3 days, depending on the progress of the patient. Sometimes there can be very hard crusts, which can be very difficult to remove with irrigation. In that case, they should be first loosened and mechanically removed with the help of a forceps. Now, what do we use to do this nasal irrigation? There are two formulations that we can use. The first one is an alkaline nasal douching. And the second one is a buffered hypertonic saline nasal irrigation. So these are the two solutions that are used to do nasal irrigation. Alkaline nasal irrigation, this includes a very specific combination of elements. First is you add 1 part sodium bicarbonate, you add 1 part of sodium biborate, and you add 2 parts of sodium chloride. And all of this is mixed in 280 ml of water. And the solution that forms from this is used to do nasal irrigation. Now, what are the importance of adding all these different elements over here, different components over here? Sodium bicarbonate is alkaline, and this helps in effervescence, which helps in removal of the crusts. Then sodium biborate is an antiseptic action, has an antiseptic action, and the sodium chloride acts as a vehicle over here. So all these three components that you see have their own roles, and together they help in nasal irrigation. Next one is the buffered hypertonic saline nasal irrigation. Here what you do is in 250 ml of water, you add 2 to 3 teaspoon of pickling salt and 1 teaspoon of sodium bicarbonate. And once you mix this, this is used to do irrigation of the nose. The benefits of these doing this nasal irrigation is that it washes off all the crusts and debris, and this salt, the salt that you have added over here, that it pulls out the fluid out of the swollen membranes. So this is about the first medical treatment, that is nasal irrigation and removal of crust. Second is, after you have done nasal irrigation and removed the crust, you paint the nose with 25% glucose and glycerin. And why do we do this? What is the importance over here? What is the role of glucose and glycerin over here? So first of all, let's know the exact composition that we add over here. We add 8 gram of glucose in 30 cc of glycerin. And what is the role of glucose and glycerin over here? Glucose is a bacteriostatic agent. So the glucose helps in inhibiting the growth of bacteria. Bacteria usually need a mucin medium for proliferation and growth. Here, by adding glucose, we make it a glucose medium. Hence, because they are not able to get a mucin medium, the bacteria does not grow. And that is how this 8 gram glucose over here is acting as a bacteriostatic agent. And presence of lactic acid creates an acidic pH, which becomes unfavorable for the growth of the organism. And what is the role of glycerin? Glycerin is actually a hygroscopic agent. What does hygroscopic mean? Hygroscopic means a substance which can basically absorb the water from the environment. So what glycerin does is it moistens the area by absorbing the water from the environment. This is its role, and it is also kind of a mild irritant, and because of which it can lead to some increased vascularity in the nasal mucosa. Because the primary problem over here is also because there is obliterative endarteritis, and the vessels inside the nasal mucosa start to atrophy. So this is the reason why you add 25% glucose and glycerin inside the nose after you have already done the nasal irrigation. Next, we move on to chemicitin anti-ozena solution. These are like smaller options that are available. So chemicitin anti-ozena solution, this contains chloramphenicol, estradiol, vitamin D2, and propylene glycol. This whole solution is locally painted in the nose, and it kind of helps to eliminate any secondary infection of the nose. All the bacteria that we have heard of that we find as a secondary invader of the nose, like Klebsiella ozeni, the Proteus vulgaris, Escherichia coli, etc. This can be treated with the chemicitin anti-ozena solution. Next is estradiol spray. While I was describing the two different types of primary atrophic rhinitis, type 1 and type 2, I mentioned about how estradiol spray can actually help in type 1, because here it will help in regeneration of the seromucinous glands and also increase the vascularity of the nasal mucosa by doing vasodilatation. Whereas in type 2, we already see a vasodilatation of the capillaries present. So here if you use estradiol, it actually worsens the condition. Next option is placental extract. Usually, you give a submucosal injection of the placental extract. This can also help in regeneration of the nasal mucosa. Next is potassium iodide, which is usually given orally. It promotes and liquefies nasal secretion. And lastly, you can use oral streptomycin. The dose used usually is 1 gram per day for 10 days. This helps in reducing the crusting and odor. This is very effective against Klebsiella. So, these are all the medical treatments that you can give. First, being the most important, being nasal irrigation and removal of crust. The two different nasal douching that the materials that are used for nasal douching, one is alkaline nasal douching, the composition of it, what is the importance of each part of it. Second is buffered hypotonic saline nasal irrigation. Second, here is 25% glucose and glycerin. What is the dose that is used? How is it used? And what is the mechanism of action of glucose and glycerin in treating the disease over here? Chemicitin antiozina solution, estradiol spray, placental extract, potassium iodide, and oral streptomycin. So these are all the medical treatment. Now we move on to surgical treatment. There are a lot of different operations. The most common one that you'll hear in relation to atrophic rhinitis is the Young's operation and the modified Young's operation. Then there are a group of operations, surgeries, which are done to narrow the nasal cavity because you get a huge roomy nasal cavities here. So symptomatically, when you want to treat it, you want to narrow the nasal cavities. The different options here are Lautenschlager operation, Wilson operation, inserting fat, cartilage, bone, or Teflon strips, triocyte and fibrin implantation, and plastic pore implantation. Then there's other ones like Whitmeck's operation, stellate ganglion block, and vestibuloplasty. So let's start with the first one, which is Young's operation. What we do in Young's operation is we do a circumferential flap elevation. The left side that you see is the Young's operation, what the nose will look like, the nostril will look like at the end of Young's operation. Here we do a circumferential flap elevation from all sides, 1 centimeter cephalic to the alar rim, and we place sutures in the center of this elevated flap. The purpose of this is basically to close the nasal cavity completely. And once you've this was the first operation that was done earlier. And once you do on the first side, after 3 months, you do on the second side. And you give a time period of about 6 months or even later, after which you open this. And here, what happens is a lot of the times it has been seen that the mucosa kind of reverts back to a normal mucosa, and the crusting of the nasal cavity has actually reduced because of the closure of not getting exposed to the environment, the air currents. However, this operation came with its own disadvantages. It is difficult to kind of elevate the whole circumferential flap. Sometimes this central suture area that you can see over here, this can actually break down very easily. So there is no room for cleaning the nose for a period of 6 months or even more. You can also cannot bring the patient for follow-up because you cannot examine the nose over here. And it has also been associated with increased recurrence. And also, the very fact that if both the nose are closed down, there will be a bilateral nasal obstruction. This can actually be a huge discomfort to the patient. So, from the Young's operation, a little bit modification was done, and then we came to something known as modified Young's operation, which you can see in the right side over here, the left nostril. Here, what is done is instead of completely closing the nostril, you only partially close the nostril and you leave about a gap of about 3 millimeter of size in this closure. So, as a result of which, what happens is it is easier than Young's, where you get to have nasal breathing despite the operation. So, this is preferred because you can do both sides at the same time. This will not lead to complete nasal obstruction. The patient can have their own nasal breathing. Even the voice is not going to be a denasal voice. You can perform a little bit of anterior rhinoscopy and do checks on the patient. And this is also cosmetically better for females who are in the marriageable age. So this is definitely a better operation than a modified Young's operation. And even the suture line breakdown is less common over here. However, this also comes with its own disadvantages. It is not possible to do when there is a large septal defect, and this also does not allow for cleaning of the nose, as for the case of Young's operation as well. And again, this is also involved with some recurrences. So these are the two main operations, the first two main operations that came about for this Young's operation, and with its modification, modified Young's operation, where you do a partial closure of the nose and keeping a 3 millimeter size opening. Next, we move on to all the surgeries that are associated with narrowing of the nasal cavities. So, because the patient comes to you with very wide, roomy nasal cavities, and air currents entering the nose will dry up the secretions, leading to constant crusting. So, to deal with that, symptomatically to treat the patient, there are few techniques which have been popular to reduce the size of the nasal cavity. The first one is a Lawton-Slager operation, where you fracture the lateral wall and you displace it medially. So, as a result of which, what happens is the size of the nasal cavity is narrowed. Next is a Wilson's operation. In Wilson's operation, you inject a suspension of powdered Teflon and 50% glycerin paste inside the nose. Thirdly, you can also insert some material like fat, cartilage, bone, or Teflon strip under the mucoperiosteum of the floor and lateral wall of the nose and mucoperichondrium of the septum. The fourth material that is used is a triosite and fibrin. Triosite is a combination of 60% hydroxyapatite and 40% calcium triphosphate. Now, triosite mixed with fibrin in a 1:1 ratio can also be injected or inserted under the periosteum of the floor. This also yields very good results, and material can be molded very easily. You can see over here, this is the wide roomy nasal cavity. And after injection of the triosite and fibrin, how it reduces the size of the nasal cavity. However, this also again has its own disadvantages, like the material can leak, it can lead to infection of the material, and also cause potential damage to the lacrimal system. The fifth operation for narrowing the nasal cavity is plastipore implantation. Plastipore is a very porous material which can actually allow tissue ingrowth within it. It is kind of fenestrated, so there is room for tissue ingrowth into the material. So these implants are usually placed submucosally along the septum and the nasal floor. This advantage is that it's very easy to do, there is a very low extrusion rate, and it can be easily done under local anesthesia. And disadvantage that it requires the presence of septal mucosa, and there is a very small chance of extrusion happening. The last three operations, which are usually not as much done, are Whitmick's operation, where a salivary duct transposition is done into the maxillary sinus. Next is a stellate ganglion block, which is done to increase the nasal secretions. And last of all is a vestibuloplasty, where a flap is raised from the lateral wall of the nasal vestibule and sutured on itself, thus decreasing the lateral flow of air into the nasal cavity. So these are all the surgical treatment of atrophic rhinitis that is there. Next, what is the prognosis of these patients? Usually, this condition persists for many years. It starts around puberty, persists for many years, and it has a tendency to recover sometime during the middle age. Especially in female, that it's seen that after menopause, it starts to cease. The foul odor and the crust formation starts to cease down. Lastly, is what is the differential diagnosis of a patient who presents with the features, clinical features, same clinical features as that of atrophic rhinitis? It can possibly be a nasal or a paranasal sinus tumor, purulent rhinitis, purulent sinusitis, nasal diphtheria, tuberculosis of nasal mucosa, gamma, intranasal foreign body, or even something as rare as nasal cholesteatoma. So, this is all about atrophic rhinitis. This, I hope I've been able to explain it properly and easily to you. And this can very well help you in writing a long answer in your theory questions, or even answer your Viva questions, and if this case comes as a short case to you. If you have any more questions about this, please put it down in the comment section and I'll definitely reply back to you. Thank you. See you in my next video.